Welcome back, doctors. Today we are crushing a high-yield topic for your residency exams and clinical rounds, which is the landscape of schizophrenia subtypes. We are moving beyond just the DSM-5 criteria to look at the historical context, the classical clinical subtypes, and the rare variants that examiners love to ask about. If you want to master psychopathology, you are in the right place. Let us start with the history because you cannot understand where we are without knowing where we came from. It started with Morel, who coined dementia precoce, describing cognitive failure in the young. Kraepelin then gave us the term Hebephrenia. But the real game changer was Morel and Kraepelin. He synthesized Hebephrenia, Catatonia, and paranoid types into one deteriorating entity called dementia precox. Later, Eugen Bleuler shifted the focus from the outcome to the mechanism, coining the term schizophrenia, or the splitting of the mind, and gave us the famous 4As. Kurt Schneider then tried to narrow it down with his first-rank symptoms like auditory hallucinations and passivity phenomena. Now let us dive into the classical clinical subtypes. Even if the DSM-5 has moved away from these, you will see them on the wards and in older textbooks. First is paranoid schizophrenia. These patients have stable, systematized delusions and frequent auditory hallucinations. Crucially, their affect and volition are relatively preserved. The prognosis here is generally favorable compared to others, but watch out for calculated violence based on their delusions. Second is Hebephrenic or disorganized schizophrenia. This has an early, insidious onset. You will see disorganized thinking, word salad, and inappropriate or flat affect. The prognosis is poor, often leading to a progressive deficit state requiring long-term care. Third is catatonic schizophrenia. This is a psychomotor disturbance. It can range from stupor with waxy flexibility to dangerous catatonic excitement. Remember, catatonic stupor is a psychiatric emergency due to risks like DVT and dehydration. The primary treatment is ECT, and the benzodiazepine challenge is your diagnostic best friend here. Fourth is simple schizophrenia. This is tricky. It is an insidious loss of ambition and social withdrawal without clear hallucinations or delusions. It has a very poor long-term outcome because it is hard to treat pharmacologically. Finally, we have residual and undifferentiated. Residual is when the active phase is over but negative symptoms remain. Undifferentiated is the catch-all for cases that do not fit the other boxes. Moving on to the schizophrenia spectrum variants. Schizoaffective disorder is a major exam favorite. This is a major mood episode concurrent with active phase schizophrenia symptoms. The key diagnostic point is that there must be at least 2 weeks of psychosis without mood symptoms. Schizophreniform disorder is essentially schizophrenia but shorter. The duration is between 2 weeks and 6 months. About 70% of these patients will eventually convert to schizophrenia or schizoaffective disorder. Now, for a theoretical model that explains the biology, we have Crow's 2 syndrome hypothesis. Type 1 is the positive syndrome. Hallucinations and delusions dominate. It usually has an acute onset, good response to antipsychotics, and a favorable outcome. Type 2 is the negative syndrome. This is dominated by apathy, alogia, and avolition. It is linked to structural brain changes like ventricular enlargement, responds poorly to meds, and has a poor prognosis. Let us finish strong with the unusual variants. These are rare, but mentioning them shows you really know your stuff. Pfropf schizophrenia or engrafted schizophrenia is when schizophrenia arises in someone with a pre-existing intellectual disability. Gogh syndrome involves severe self-mutilation during psychosis, often due to command hallucinations. Oniroid schizophrenia is a dreamlike state where the patient is lost in an internal fantasy while continuing routine activities. Pseudoneurotic schizophrenia presents with pan-anxiety and neurotic symptoms that mask the underlying psychosis. And finally, Bouffée Délirante, a French concept describing an acute delusional psychosis with sudden onset that typically resolves fully within 3 months. That is your rapid review of schizophrenia subtypes. If you found this breakdown helpful for your residency prep, make sure to like and subscribe so you do not miss our next deep dive into psychopharmacology. See you in the next one.